All right, looks like we're going live. It's Thursday, 8 o'clock here in Michigan. Hope you guys are doing great. I'm just going to give it a second to see if our streams are coming in. We've got an interesting one today because I think we have Instagram joining us today, which is kind of wild. We haven't done that yet, so we'll see how that's going to fly. And we will just get rocking. There's a lot of stuff on my screen tonight. So tonight, we're going to do some Q&A. We left off last week, was really great. And we had a whole bunch of questions kind of still left in the hopper. So we thought we'd take this week and go ahead and see if we could run those down. Just have a nice conversation here as we get ready for our 4th of July week coming up. Dr. Marcico's in the chat, so I know we're at least streaming to someone. We'll see if that continues to be a thing going forward. And off we shall go. So, until then, I think we can just start by saying thanks for everybody kind of joining in last week. Had a bunch of really good questions, had a really good conversation. We kind of started it off with a little PowerPoint slide. And I don't know if maybe people are waiting for that today. We've got Amanda, we've got Mathieson in the house. What's up? Ready to rock? If you guys got some questions, now is our moment. Let's see if I'm live on Instagram here. Oh, looks like I am. It's weird because it's delayed and I can see it on my screen, but off we go. We'll give it a run. Let's try it out. Instagrammers, let us know what you think. Also, we will just, I'm sure it will get pushed down, but it's probably worth noting that those of you that are watching on Instagram this week, I think there is a 1 hour time limit, and sometimes we go a little longer than that. So if that's true for you, then you may want to join us at YouTube and be able to join the whole thing, hop in the chat, have some fun with us there. So let's talk about brains. And I don't think I am up on Twitter today because I have Restream, and the account that I use gives me 3 different venues to pick from. So in the scramble today, we dropped out of Twitter and we are in Instagram for fun. We'll see how it goes. Corey Block, I'm seeing you in 2 places. What could be better? So we're off and running. And yeah, we're going to have some fun tonight. So why don't you guys, if you want, Nomad Over Normals here. Jolisa, Big Erm's got a question. Peace, Love, Mungbean is in. Fatima, we're ready to rock. Christy Lee, hello. Amanda Sutherland. Eileen, Bodyguard in the house. Love it. He's probably been out working. I'd like to hear how it's going out on the dairy there. I'm a dog too. Dr. Marcico. Cool. We're rocking and rolling. Here come the questions. We got Big Erm's going to lead us off tonight. Good to see you, Big Erm. I'm going to read it out loud for everyone. I have a question. Mainly, when is the next exciting treatment coming? Oh man, it's moving around on me. Hold on. When is the next exciting treatment coming? When will I be cured? I'd also settle for effective POTS treatment. Big Erm, I would love to hear more about that. So we've been talking a whole bunch on our live streams, trying to get a sense of mechanisms underneath it. I'm curious to see if that's helped to be able to just find anybody near you, available to you, that's helped you just kind of think about things differently, and if we can work that forward, because that would be super cool. Obviously, we are here in Michigan. I don't know where you are in the world, but I would love to be able to be whatever we can to help you heal up, and if we can put some of these ideas in front of other people, and maybe they'll take a listen, then that would sure as heck help you be able to get on with your life. So that's what I'm rooting for. Gosh, wish I could help you right now. Mathieson, big improvements this week in neglect in what you previously called a snarl sign. I actually haven't had any doc talk to me about the snarl sign. Could you talk about why it happens? Oh man. So I hesitate to do this one because it's not like this is based on observation, where we will see during certain movements, we will see an asymmetry that happens in the face where someone's lip will kind of curl up, kind of like Elvis. Maybe that's a better way to put it, like an Elvis sign. And you'll see this nasolabial fold will come up, and the corner of the mouth will come up, and it kind of looks like a snarl, right? And we notice that in release signs within facial muscles, that tends to be one of the things that we see. So you think about like what are the muscles associated with that movement, right? With smiling, with frowning, with all the facial movements, those are from the facial nerve. That's the motor nerve. So what we're looking for are these little escapes in facial expression, especially when they're unilateral, to help us understand. If you trace that facial nerve back, it turns out it goes right back into the brainstem, kind of into that pontomedullary area, right in the area where there's a trigeminal system. Vestibular system's right below that. We get all the integrators of the NTS. So when we're seeing people that are hyper-aroused, or they're having escape, like too much activity is happening, they're hyperkinetic, then we can see that snarl sign will be present, and we want to see what it's linked to. So if someone's tracking with their eyes, and we notice that it tends to come up there, then that's an indicator that maybe when we're in that context using that portion of the brain, then we're kind of bleeding through some signal in that area. So what Mathias is talking about here, looking at a neglect syndrome, excuse me, so neglect is basically when we don't feel a part of our body, we don't see a part of our visual world, and that may be the whole kit and caboodle, or it may be just related to, like, I don't feel this half of my body, I feel dizzy when I try to engage in that side of space, and there are things that we can do to help recreate some of that stimulation, remap those systems so that we can get them back online again, which is super cool. And what you're talking about with the snarl sign can be part of that as well when we look at the hyperkinetic component coming in. So why it happens is a release, so it's hyperkinetic, there's too much movement, and we're seeing one movement pattern spilling over into activity within that facial nerve. Cool. Amanda Sutherland says, pretty soon I will need to start a Twitch. I understand that is for gamers. That is about the extent of my knowledge base. You'll have to set that up for me. Susan B says, hello. Last week I told you, Amanda Bailey says, last week I told you I had a brain surgery and you want to know a little more about the gap from surgery to pause. Okay. We work toward that. Sarah, good to see ya. Ray J says, hello, Dr. Nate, let's roll. Cameron Y. Dr. Keiser, I wonder if you can explain the vestibular autonomic reflex and how chronic ear issues can be related to dysautonomia. Good question. Let's kind of start at the beginning with that. It's classically looked at as the vestibulosympathetic reflex. And when you think about the sympathetic component of that reflex, right, so you have the vestibular system means my head is somehow moving or engaging with gravity. And that is going to signal when I have fluctuations in that relationship with gravity, it's going to signal areas in my brain to talk to my blood vessels to be able to shunt blood based on where my head is in relationship to my heart. So if I can know where my head is, wherever I'm moving around, laying down, sitting up, bending forward, and that can help me understand how much pressure I need to put toward my head, and that becomes pretty useful. So it's always on. It's just going to be dynamic related to the type of head movements we have. Number one, for the position, but then number two, for being able to understand where we're going to shunt blood for utility. So they're going to affect the big vessels that kind of push blood around through our muscle sympathetic nerve activity. And they're also going to affect the vessels in the brain where we have sympathetic nerves that are going to control kind of the tonicity of the blood vessels in the brain, so they can manipulate that. And that's all reflexive before anything ever happens. It's interesting because the most kind of potent vestibulosympathetic response happens in kind of head up pitch. So like if you're laying down and I start to lift my head up, that is the biggest signal, the largest influx of signal that happens within that vestibular system. So the add-on to that question was, how do chronic ear issues affect that? And the type of ear issue really matters, because if I have something where I'm in my external ear, or it's where I'm hearing, that's going to have a different impact than if it's in my inner ear. Like the external ear is, to interpret sounds, to bring in sounds, turn them into electrical signals, whereas the inner ear is going to be my balance center. So when we're looking at the vestibulo-autonomic or the vestibulo-sympathetic reflexes, these are largely due to the balance systems being activated. And if those systems have errors either in the ear itself or in the connections in the brainstem, then we're going to see the downstream effect of that can be that we have vestibulosympathetic errors, so that when we're moving our head, we don't get the adequate signal saying like, hey, let's get blood flow there. And we can see errors in that. And those can be really evident, especially on a tilt test, because that's what we are looking at in that phase as we come up. Do we know where our head is relative to the body? So great question. I'm not sure that I fully got into like the ear issue part, but if it's the hearing side, that may not have as much of an effect as if it's also affecting the balance component. And it's not just necessarily in the ear, it can be in its projections as it sends that signal into the brain and brainstem. Cool. All right. All right, so next on our list we have Nadine. Welcome. It says, hey, it's Nadine. Can't wait to see you with my daughter soon. I'm looking forward to that. I can't wait to be helpful. So thanks for being here. Dennis H. I've been noticing that my symptoms flare up whenever the barometric pressure goes up or down. Typically lightheaded on the drops and head pressure when the pressure goes up. Is that common? This is actually something that is very common, and we can almost predict it in the office. And we look at it through barometric pressure, just like looking at the app on your phone when you wake up in the morning. And then also, like, my little secret is I will notice that when I wake my kids up in the morning and they've had just like a normal night's sleep, they're not staying up too late, nothing like that. If that's happened and they're really groggy and kind of slow to get rolling in the morning, that's usually my cue to be like, I need to check the pressure today. And on those days are days that in the clinic, we can kind of feel everybody's going to be a little bit like not running top notch. And that's a pretty common deal. Now, why it happens, there can be different reasons, and some of which we're kind of not even sure about. But we know that the way that we detect pressure in the inner ear, in the brain, and in all of our tissues is all related. And it gets projected into particularly the NTS on the basic level, and then it gets projected into the brain. So if we have problems with baroreception, as we normally think about that relative to, I'm going to talk about it in terms of blood vessels, but we also have baroreceptors that detect just pressure in the body and then also in your ears, right? So that's why your ears pop and you go too low in the pool and they have to equilibrate. So, pool, airplane, kind of that difference. You go up in the mountains, then your ears will have some difficulty clearing, changing of pressure like that. So if our otolithic system, the baroreceptor system in the ear is struggling, or we're already a little behind the 8 ball, then in those people, they may be even more sensitive to changes in barometric pressure. One of the things that we do, just as a little cheat, because a lot of people that are coming here fly, and they have a hard time just with the pressure changes in the plane. And Dr. Ginny, you may remember the name of them, but I'm forgetting it offhand. They're pretty easy to find on just like Amazon. But there are these little earplugs that they make that have a hole in the middle. And what it does is it kind of blunts the pressure change that someone experiences. So the pressure will still change, it just does it more slowly and more gradually, which is easier for people to be able to tolerate those changes, especially on a quick up and down flight. All right, Big Erm says, Toronto's kind of a no-go. 3 years, not accepting patients, sadly. 5-hour drive. Maybe we'll see you soon. Let's see what we can find. Amanda Bailey, I'm experiencing POTS symptoms before surgery. I was experiencing POTS symptoms before surgery. Didn't correlate them. That's not uncommon. But after surgery, dizziness, palpitations, shortness of breath, and specifically the syncope appeared. Yeah, so post-surgical can be a little bit of a wild journey, because we've got a couple different things that are going to happen. Number one, we're injuring tissue. Like it or not, like we're cutting into people, that's going to generate an immune response. You got to heal. Things happen, right? Second piece is anesthesia can be a bit of a wild game. You're literally changing your own consciousness. You're changing the electricity flow to the brain, which is amazing. but also can come with downsides. There are a lot of stories of people that are put in positions during surgeries that when they put them in a certain position and then they pass them out, we can create different types of occlusions in the vascular system. And people didn't used to recognize them. We're getting better at that now. People notice that. But for a while, even doing, the irony is you'd have something like a carotid endarterectomy, right? Which what that means is if your carotid's all gunked up, like you picture a pipe that's just got a bunch of crap in it, and then the hole's smaller, you can't, it starts to clog up. What they used to do was cut them open and kind of rotor-root them out. But in order to do that, you got to turn someone's head. And what they were finding, though, was in a higher than desired portion of cases, they'd do that and they'd pass them, they'd pass somebody out with their head cocked over like that, and they would have a stroke because when they would turn their head, they were actually occluding the other vessels and having a stroke in the brain as they're trying to clear out the other vessel, which is the worst. So if you think about that, positioning really matters. Making sure that the anesthesia is appropriate, not too much, there's not a bad reaction to anesthesia. And we've talked about that in the live streams before. So it's hard to know precisely what the mechanism is from surgery, but it can be a thing. It is a thing that we see where people will know, like, that was a catalyst for making my symptoms worse after that. Figure making a plea for pro bono, also offering to pay in baked goods, which I really appreciate. Depending on quality, I don't know what you're working with there, but see what kind of baked goods you got running. Sarah says, what's the best way to handle stairs for someone who has a POTS type situation? Best to walk more after or take the rest and being heart rate down. Let me read that again. What is the best way to handle stairs for someone with POTS? Best to walk more after or take the rest and bring I bet that's bring the heart rate down, not being heart rate down. Yeah, so great question. I can't have there's not a good pat answer for this, because for some people it's like, why is stairs the issue? Why is the POTS there? So for people that are just ripping tachycardia and it might be related to pooling, for example, let's say, in that case, you might actually benefit in some degree from, like, if it's, let's call it small fiber neuropathy, right? So you might benefit from the action of doing the stairs in some ways, and then have to recover once you get to the top. That's probably for a lot of people is tackling the stairs. If you know you're not going to pass out, that's not the dangerous part. It just feels overwhelming. Then we can get to the top, rest, and then kind of like catch your breath and move along. That's probably best for most people. Most people, if you notice though that like once I get up and moving, I do better, then obviously you'll want to keep going. That's not most people though. Now I say that like with giant parentheses and like an asterisk by it, because we don't know for sure why it would be. But if you're just saying like, I need to go upstairs because I need to use the bathroom, I know I want to solve the root problem stuff, but for right now, I just need to get up the stairs today. In those cases, yeah, we want to try to get you up the stairs. You can scoot up the stairs, walk up the stairs, use your handles, as much support as you can use. And when you get to the top or get to the bottom, getting into a recovery position and then moving along from there. So I know that's super hard on people. That's a big challenge we have. Even just finding people places to stay is working around stairs and exercise again. So trying to build that up is a big deal. I'll answer that question a little bit more for our folks that have neck stuff. Sometimes that stair component can put you into a position that is not advantageous for your particular thing. So that is a secondary consideration, is that if we've got some of those neck problems and we're looking down at our feet, some people that may make them worse. So we may actually need to modulate, like fix your head as you're walking up and down the stairs as well in those cases. So that's why it's kind of hard to give a lot of nuance, because for different people, we can change that in different ways. So I'll leave it there. But Michelle gave us a nice heart. Thank you so much. Let me see. Switz or Switz. I have endometriosis, POTS, and possibly either MCAS or histamine overload. Is it possible to heal from POTS and MCAS? How do I figure out the root cause? The hot weather is ruthless with my symptoms. Great question. So for me, I've been doing this for so long that I kind of forget and I skip right past the question of like, can anything even be done? Because I forget that is like the first primary question that people have on the internet, because if most places you look say, no, nothing can be done. That has not been my experience. My experience has been, for a lot of people, there is a reproducible way to train through POTS symptoms. Now, not everyone has POTS the same way. It's just a big grouping of people that have a high heart rate. But by being able to dial in and understand the mechanism, for a lot of people, that leads us to a path forward, which is really, really cool. But also there's work involved. So that's my experience with it. We see a lot of people be able to make huge improvements in their lives, and that matters a ton. And sometimes I forget to say that like, yes, like you should probably pursue trying to solve that problem. Even if you're getting a lot of pushback from people that tell you it's not true, get rid of them. They're not useful to you. For sure, hot weather is going to be a thing this time of year. We're in the summer now. We just had our longest day of the year, which is pretty cool. So heat is, for most people with POTS, going to be an issue. For some of you, this is not new for me to talk about, but heat is going to generally pull blood to the skin, helps us with cooling, helps red blood cells get some much needed love from the sun, and it's going to pull it into the skin. When it pulls blood flow into the skin, you've got less in the circulation between your heart and your brain. And if you're getting symptoms because you're not getting enough blood in your brain, we're going to exacerbate them in the heat. It's also going to make it harder just to deal with autonomic functions related to heat and cold, like being able to cool yourself, being able to regulate your temperature. So those are definitely parts that people experience, but there's like some brilliance in this too, because now is the time of year where we can start introducing people back into the heat in lower doses and being able to start pushing that. A lot of POTS people have been indoors in a pretty static temperature for a long time. And so if you're only used to like the discrepancy between 70 and 72 degrees, and then we ask you to go into 80 degrees, that's a big deal. That's a jump for your body. So we've got to be able to slowly expand that range of what you're tolerant of, both on the hot side and on the cold side, so that we can kind of exercise that thermoregulatory system so they can tolerate more heat, tolerate more cold. On the cold side, like Raynaud's, stiffness, pain, coldness in the joints is going to be a big deal, right? So stretching that out by giving some exposures. We expose you to temperature the same way we'd expose you to any other stimulus, a little bit at a time, enough so that you can tolerate it and not fall over the cliff, okay? But yeah, as far as getting to the root cause, we've got a bunch of videos about things that we're doing to look at different mechanisms in the brain, vasculature, nervous system writ large, to be able to understand why is the body responding this way. We kind of start from the core position of your body's always trying to do the best thing for you. It's trying to always optimize in the most efficient way possible. Your brain is constantly searching for efficient. So whatever you're doing right now is the most efficient version of that. But if we can think about how do we give it more efficient ways so that we're not burning up all this bandwidth and energy just moving blood to the head, how do we make this work better? That opens up this whole new door, whole new world of options for people once they decide like, oh, this is the problem I'm trying to solve. Okay. Good luck. Switz. Matheson said, why do some concussion patients get chronic inflammation? Will it go away by itself once the concussion has been treated? So I think it's important. I think it's really important to look at inflammation for what it is. It's been kind of turned into a bad word, but inflammation is just your body's mechanism for healing. So if someone's chronically inflamed, it means there is a condition within the body that is not able to finish the healing process. Whether that means it's extended in duration or it continues to be injured over time. Those are kind of the roles of inflammation. And then we kind of end up where we always end up with me, so apologize for that. But we end up backing out to a new question of like, well, why is it there? So if my body is constantly dealing with this inflammatory load, why? Is it because we have an inefficiency in the healing process? Is it because the way my life is going at the moment, I'm not allowing it to get to that like full level of healing? Is my immune system not competent to do the healing, or is it overreacting to it? Both of those are functions of feedback loops in the brain. And if you can start to drill in on some of those questions, then it makes it more realistic. In a concussion, you may be looking at a duration problem. You may be looking at a feedback problem. That's pretty common. And we ultimately want to support that inflammatory system to get it done, rather than just use a mechanism of steal it away and then hope everything gets better. I think that's a pretty short-sighted way for physicians to look at it. I wish we wouldn't look at it that way. I wish we'd do things to say, like, how do we support this thing healing so that it can move along? And for concussion, a lot of that ends up thinking about mechanisms inside the brain. How do we make this brain work better again? Good question. And Thiessen always coming in strong. All right. Ash. So let me take 1 second before I answer Ash's question. I can see that there are questions on the Instagram stream, which I'm really thankful for. It's hard for me to get them because they like scroll through super fast. I don't know if there's any way where you can jump to the YouTube stream. Not that I'm trying to take people away from Instagram. Love it, great platform, everybody stay. But if we can organize them into, I can kind of see it all pull into chat with YouTube and Facebook, but I don't think I'm getting, let me just make sure, I don't think I'm getting ones from Instagram. So if you got a burning question and you really want to get it done, that might be the way to do it. Cool. Okay. So Ash says, I went 3 weeks without a crash. Nice job, by the way. Well played. Did a 12-hour workday and it triggered me. Now I'm in a week-long dysregulated nervous system. Okay, but that's not unreasonable. And it doesn't mean it's dysregulated either. So 3 weeks without a crash, 12-hour workday is a long workday. So if you think about like the process of recovery is just this like stepwise journey toward getting some more endurance, right? Okay, so you could also think about like what is another version of our life where we take like a stepwise process toward creating endurance. The one that comes to my mind is like a marathon training. And so if you're just cruising along, like doing, your small mileage, if it's me, it's like you're running maybe a mile at a time and then you're cooked. But if you're someone that's working toward running for a marathon and all of a sudden, you're used to a mile and all of a sudden one day you're like, I'm going to do 12, you're going to be sore the next day. That doesn't mean that you harmed anything, right? But it means your body's got to do some catching up and recovering. So when we have those big spikes of output that you guys will see, and people comment on these all the time in the chat, those big spikes of output, there's going to be a longer protracted recovery time with that. Even better is if you've got some tools within that recovery time that help to pull that system back down, then that is great. It's not necessarily dysregulated though, it's just not capable of dealing with that kind of load yet. It just means we got to keep building strength to be able to tolerate it. Now 12 hours, that's a work day. And if we can work sub-threshold to that and work back up into it, let's see if we can get there without having that kind of like delay in recovery or inadequate recovery. It just means the recovery system isn't strong enough yet to be able to take on that load, but it doesn't mean it won't be. It's just like a really great indicator that like, okay, now we've got a line where that's a lot. Let's keep working and keep doing the things you're doing from there. So I think that's exciting. Honestly, most patients that end up coming through our office that have that experience, right? Where they're cruising and they're like, I'm doing really good. 3 weeks, no crash. And then you start kind of like letting your hair down a little bit. And when that happens, then you find the upper limit. Just because you find the upper limit of where your endurance is doesn't mean that you've done anything bad. It just means that like, okay, that's a point we're trying to work toward. So I just want to encourage you on that. I think it's actually really good news. Just keep pushing it. Language around, I wouldn't use dysregulated nervous system, because that feels like something's done wrong. It just means it's not caught up enough yet, right? So it's still a work in progress. It's still trying to build that recovery system back up. So give that body and brain of yours a little grace. All right, Dr. Ginia is relating a question from somebody that can't be here. She said, if a Doppler confirms impaired venous drainage, from where I'm not sure, how does this affect arterial blood flow in the brain? Can hypoperfusion be present? So I'm going to have to make a lot of assumptions to answer this question. But the assumptions you have to make is that we're in a short loop between the arterial and venous system. So I'm assuming this is in the head. I'm assuming we're looking at venous drainage, let's call it in the neck. And then we're saying, can that have an effect on the ability to create arterial perfusion as well? So a couple things. We want to understand first, where is the impaired venous drainage coming from? So if we're using our example in the neck, is it being impaired physically, like it's being compressed structurally, and it's kind of pinching it, blocking it, we're creating a kink? It's going to back up from that point upward. So if that's in the upper cervical area, that's a common place, then it's going to back it up into the brain. It's going to drag it up into the internal jugular veins, into the transverse sinus, and it's going to kind of move up. It's bilateral, so if one side's blocked up, it's going to tend to really drive the flow from the other side, and you may see some distension related to the other side. Now, we can also have blockages that occur a little bit lower. Second common place is in the thoracic outlet. So in the area between the ribs and the clavicle, we can also block it here. And if we block it there, again, you'll see the same thing. This is what's called retrograde flow, where it backs up into the neck and possibly into the head. Again, same thing. It'll try to drain and flip over to the other side best it can. And it'll just drain as much as it can. But you can see these with Doppler. You can also see them with like CT angiography, reconstructions, where you can kind of see the diameter of the vessel. So like those are the big two, especially when we think about the head and neck. And they're going to back into the system and cause what you looked at here, which is like a sluggishness that can occur with drainage. When you have that blood that's backing up into the skull, if there is a larger amount of blood that's being pooled in the skull, it's going to mean that we're going to have to back off on some of the pressure we put in through the arterial system, because that pressure has to balance out. Is that I put in more pressure through the arterial system, it's going to push through the venous system, but only to the degree that it's able to drain out. So if it's being compressed, it's going to try to push it through, but again, it's going to kind of back up into that system as well. So if you think about, like if you've got a sink, you got a faucet, it's draining into the sink, but if the sink is clogged, the amount of fluid that's going to come through, or the amount of water that's coming through the faucet, if the faucet amount is greater than the drain amount, that's going to fill up into the sink. So you can kind of use that as a metaphor, where if I don't want to overfill the sink, then I'm going to have to turn the faucet down a little bit to be able to make sure that I'm not creating too much water in the sink or too much pressure in the head. So that it can be a metaphor to think about it through, and see if that kind of helps you understand where, especially those internal jugular veins become really important, the subclavian veins, in that thoracic outlet, being able to look at, are we able to drain effectively, or is that backing up into the head? Good question. Okay, how we doing, team? Everybody hanging in there? I can see we got a lot of questions here. I'm at 8:11. Let's see. We're in that stage where I'm sure you guys are responding to some of the questions or some of like my statements. I apologize if I'm not able to get right to them. We need a better system for that. We need like a question section and like a comment section so that I can keep up with both. But I'll do the best I can. I'll try to move through these and do it in a way that's useful for you guys. Okay, so I'm going to go back up here. Where am I? You guys really got a lot. Okay. So Irene. Oh, there's a number 1, which means there might be a number 2. Okay, so I'll try to find that. An MRI of the pituitary shows the stalk deviates to the left. The gland extends up into the intercarotid line bilaterally. This, meanwhile, cortisol fluctuates wildly. Blood pressure remains steady. Remains steady up until cortisol tanks. Post-exertional malaise sets in. BP drops to below 90. Let me shorten this down a little bit. So the question here. Okay. So I don't know that I know the question here, Irene. Thanks for sharing the notes that you have here. All right, so is this deviation of the pituitary gland? One thing to consider with cortisol fluctuating, I don't know how to read that precisely with what that means. Blood pressure remains steady. That's a good thing up until cortisol tanks. And then sounds like you start to feel some symptoms and then blood pressure will drop. Blood pressure drops below 90. I don't know if that's the systolic, diastolic, or the mean arterial pressure. But if that's dropping, I don't know that you can... It's really hard to directly correlate cortisol and blood pressure because they operate on two different time scales. They're different frequencies. Cortisol is going to be more a humoral response, whereas blood pressure is like beat to beat, happening very quickly as a neurogenic component. Think about cortisol as being a mechanism for releasing more glucose into the system. So it might make sense that if we're seeing those fluctuations in cortisol, like what's going on with that glucose system, and then seeing how that compares with blood pressure dynamics may be like a little bit of an inroad for understanding that. The relationship to the pituitary gland, I'm not certain because I probably wouldn't use those two markers as the best way to understand outputs of the pituitary. So it's hard to use those as a correlate. Question from Charles. Hello, I'm currently looking into periods of bradycardia and poor cerebral perfusion during migraines. Found a link to parasympathetic excess dysautonomia with a treatment with anticholinergics. Okay, let's walk through that. So if we're having periods of bradycardia and poor cerebral perfusion, what's really helpful to understand is if we're having changes in, well, number one, if there are symptoms that feel like problems with cerebral perfusion, or if we're measuring poor cerebral perfusion, that little bit of nuance can be really helpful because sometimes you can feel like it, but we don't know the direct representation of that. The only reason I say it is because we also need to be able to compare that to systemic blood pressure or arterial blood pressure when we think about migraines. Because in a migraine event, sometimes what we're looking at is actually overconstriction of the vasculature, especially in tissues in the head. So if we're looking at that overconstriction of the vasculature, we're creating too much resistance to flow, which is actually blocking flow. And we may find that the blood pressure is actually normal to high, but we're just blocking flow, which may be different than if someone's having bradycardia and hypotension, where that whole system's bogging down, and then we're creating the hypoperfusion. Those are two different outcomes, two different styles of treatment with that, right? So if we're finding that everything is just going down, we've got bradycardia, we've got hypotension, parasympathetic excess, if you're using anticholinergics, you're going to affect more than just the parasympathetic component of that. Because the first limb of both the sympathetic and the parasympathetic systems both use acetylcholine as a primary neurotransmitter. And then in the second half, the back leg of a sympathetic response uses adrenergic receptors. So that's like a big hammer to swing. I'm assuming maybe they know there's more to be said than just in this text. Obviously, I can't give medical advice through chat, but I would want to know on the face of it, does that bradycardia also mean hypotension, low blood pressure? Are we measuring the cerebral hypoperfusion? And are we able to look at something like a perfusion index, or if we don't have Doppler, could you look at something like a VA ratio in the fundus exam to be able to see if we're looking at vascular constriction during that migraine, which would be a completely different event. And we'd want to look at that. We'd look at those two scenarios very differently. So whether or not it's parasympathetic excess, hard to judge based on this, but you're kind of like, you're placing a big bet using that type of a treatment. Whereas I would want to find out a little bit more on that, if that's helpful. Okay. All right. Eileen Hart says, does my radiculopathy affect my head pain or my autonomic nervous system goes? I'm not sure. I'm not sure of the question there, but a radiculopathy in the neck can affect the head pain, but also it's going to be relative to irritation. Particularly with head pain, you're going to think about the greater occipital nerves. So it may not be radiculopathic in the sense that it affects the nerve root, but it can affect the nerve itself. For headache folks, when you get that headache that kind of comes from the back and around behind your eye, a lot of times it's the greater occipital nerve, and it will be often described as like a cervicogenic headache. Cervicogenic just means it comes from your neck, but it's because the muscles in the back, there's a bunch of them, but there are kind of four, if you think about it, that make this little web, almost like a hashtag, like a hash mark, where the nerve penetrates through the hole in between them. But if that neck is tight or those muscles are overactive, they can compress down on that nerve, and that's what people will feel like, that radiating pain that comes around the head to the eye. So it's not truly radiculopathic, but it is that muscle clamping down on that nerve, irritating the nerve, and then giving the sense that there's pain there because there's an irritation in the nerve that would serve that area. So that can be true, but then also you can get headaches that are going to be autonomic in nature if they're affecting the vasculature, and sometimes those will feel more like a pulsatile headache. The character is a little different. They're not kind of in that same distribution. You may feel it more around your head and around your ears, or even to the back of your head. So they can both be at large. They're both options, and some people, they can both be affected, especially if you've got a problem in the neck. They can both overlap each other as well. Okay. Dennis, another good question. Are genetic mutations like the MTHFR and the COMT common in POTS and dysautonomia patients? I read how this can cause issues with homocysteine and histamine and lead to POTS. Yeah, I think that's a good point. I would not say that I would link these two genetic mutations specifically just to people with POTS or just dysautonomia or even just ME/CFS, only to know that they're also more likely to seek out testing for these things too. So that makes it a little bit hard because you got a little bit of a user bias there. But if we're having those problems, they can slow down some of the conjugation at the level of the liver, and so they may need a little bit of support in being able to just keep things moving in that range. So homocysteine levels can go up. Homocysteine and histamine are pretty low on the list of things that are going to lead to POTS. They're actually leading to they're secondary problems. So remember, POTS, as a stickler for semantics, to be diagnosed with POTS, it means you can't have anything else. And a lot of these things are leading to, if those are primary problems, then it's the leading to something else. But also histamine levels are going to tend to be higher when you have things that affect autonomic outputs with arousal bases, and where we're affecting brain outputs that are going to create a sense of increased attention, hypervigilance. And anytime there's something wrong with someone, there's going to be hypervigilance. So if your body is hurt, sick, not doing well, but you don't have a tangible reason why, then arousal levels are going to go up, and they should. And then we see the sequela of things like the things that happen after that, and then sometimes we look at those things that happen after that and think, well, maybe those are causal, and that's not the perspective that I share with most people. That's not the place I would start from. I don't know if you guys can hear it, but I got some screaming kids outside. A lot of excitement going on over here at the Keiser household. Whew, okay, party time. All right. Eating more than a bite or two, I have to rest and digest for at least a half an hour. Eating smaller meals throughout the day leaves me feeling like all I do is eat, rest, digest. What to do? Well, this is a pretty common situation for a lot of people that have GI problems, but also that have slowness in digestion. If we go back to our marathon example from earlier, and we think about trying to build endurance as part of getting out of this scenario, you can also think about that with your digestion, right? So like the ability to eat a bigger meal is more taxing. It's harder, it's a heavier lift. And so if we have a system that isn't fully capable of doing that, it's not strong enough for that, one of the things you can do to offset it is to just eat smaller meals infrequently and let the body work through them slowly over time rather than filling that thing up and then letting it churn. So it takes a more robust system to be able to have a bigger meal, to be able to have a more nutrient dense meal, big steak, something like that. And for some people, that's just a big ask. So the question is, what can I do? Hold on one second, girlies. I'm going to finish this question and then you can come hang with me. But the question about what to do is, well, we want to see if we do things that can improve that connectivity. So if it's a problem that's happening in the gut where we're seeing the slower motility, or we're seeing it slowed down because the precursor signals are slow, or it's inflamed, or we've got gastritis or enteritis, or it's happened long enough, we've had this dysautonomia long enough where we've started to create different pH in the system, creates a different terrain, which creates SIBO or infection types of problems, then we can see all of those things have the capacity to reduce the strength and motility in that system. So then we back that out and we think, well, now I need to see how do I take all those things out of the equation as a way to see if I can get that motility to run again. Okay, girlies, come on in. Did you guys have fun?
Yes.
Oh, lovely.
We went to Sounds and Sights.
Yeah, was it cool?
Mm-hmm.
Sweet.
Did you hear the
Good hitting
screaming?
today. You guys are so loud.
That was her.
I could tell.
She was screaming at the bunny.
Oh, is that why? Why
She
did you scream at the
choked
bunny?
her. She choked her
I
stomach.
named him Bob.
Be nice to it. Goofball.
He ran like a big football.
Big football.
And his tail was like.
All right, animals, you are all sweaty. Time to take a shower. Oh, there's my bunny, huh? Mwah. Mwah.
Mwah.
Good hitting.
Thanks, Dad.
All right, go get a shower. You gotta get some sleep.
Okay.
Love you.
Love you. My earrings, Daddy.
Oh, you're showing everybody your earrings. They look lovely. Very beautiful. Okay, love you.
Love you.
Thank you for my intermission. Thanks for I don't like missing saying goodnight, so thanks for letting me do that and let me answer that last part of that question. Okay, where are we? Okay, Colson asks a good question here. Does POTS and dysautonomia cause oxidative stress? Therefore, can the brain be damaged by overexertion? I got some wildness going on in my hair. Can it be damaged by overexertion? So, in terms of its ability to do oxidative phosphorylation, which is aerobic metabolism, if we overstimulate those systems, we push the brain too hard, then yeah, we can actually cause damage by kind of as we shift from aerobic to anaerobic metabolism. Everybody is going to have some degree of loss of oxidative phosphorylation over their lifetime. That's aging. So we're kind of built to deal with it writ large, but that is a big part of what we're thinking. That's a big part of what we're thinking about with rehab. A lot of people, we're not most people's first foray into trying to solve this problem, right? Most people have been to whatever their insurance will pay for. So physical therapy, some form of, maybe loose vestibular rehab, maybe the PM&R system, all sorts of stuff, right? So it's not usually the first bet. But what we notice is for a lot of people with autonomic problems, that the application of those rehab strategies is like, we're back on that marathon example, is like we are trying to, in those scenarios, the applications are way past what people are capable of in the tissue that's injured, which is really hard to wrap your head around because you just look like a normal person. You're like, I used to be able to do this, now I can't do this, and there's certain things I can do, and it's strange. But when you're thinking about the brain, you've got these little pockets of neurons that are all communicating with each other, but if some of them aren't communicating as effectively, we can't target the whole system and hope that some of it lands in the area that needs it. You have to target the area that needs it. And usually it means we have to back down on what somebody's doing to an amount of input that they can tolerate and build from. So our example earlier was like a perfect example of that. It was like, we have to kind of just slowly feed that brain and help get it stronger and stronger and stronger at the metabolic rate it can handle, which may be like profoundly small. It may be, simple things like, can you look at this target and then also turn your head? And can we just like get really good at that? You know what I mean? So there are all of these like tiny little things that can go into the overall big, beautiful picture of your brain. But if we try to just like jam it and push too hard, then we can end up in scenarios like we're talking about here, like Colson's talking about, where we overexert the system, we push it too far, and then it has a hard time being able to get traction because we're injuring the tissue over and over again. Really good point. Okay, Irene McBean, I appreciate you sharing your MRI with us. I don't know that I can do like a fair read of the MRI through chat here, so I don't know that I'm going to try because I don't want to be misleading or miss anything, or just like I don't want to do a bad job for you. So I appreciate that you're sharing it, but I'm not precisely sure without looking at it to be able to give any comment on it. Okay, Dr. Ginny was also given some options for pressure equalizing earbuds. The good thing about those things is that they're cheap, and if they work, they work. If they don't, then But a lot of people do find that they're helpful, especially when they're traveling or if you're living up at altitude. All right, Amma. Okay, experiencing POTS-like symptoms, but all tests come back normal. I'd be curious to know what all tests are, because I'm betting not all tests would come back normal if we did all the tests. So like, maybe we should do more. But can a misalignment in the neck cause this similar symptoms? It can, but again, that would be a test that you could figure out if that's the problem. So it'd be it's good to put all of those things into the same system. So it's hard to get a good answer if you're trying to look at it and go, I should see my cardiologist to look at my heart, and then my neurologist to look at my brain, and then I'll go to the vestibular specialist to think about my inner ear, and then the PT or the chiropractor to think about my neck. I think that's a really tough way to approach it because all of those things interact together. So my perspective on that is they should all be looked at the same time in the same context to understand how they're working together, and that the fact of that whether they are working together or not well points you toward what can be the cause. So can misalignment be a thing? Absolutely, but I have no way to know other than to do some more tests. That sounds like if I were looking at this, that would be the range I'd want to look in. It's like, let's get some more things done. Secondly, can intracranial hypertension caused by misalignment blocking the jugular drainage cause floaters in the eyes? Again, we'd have to look at that. Maybe we're skipping ahead and that's a thing that you have. I don't. Can it cause floaters? Floaters are going to be like protein based in the eyes, so that may not be the thing, but can it cause visual disturbance? It can. So there's a big question there. We'd have to have some more information. So it's hard to answer those specifically for people without knowing, because that's how number one, we don't do it, but number two, trying to make guesses without all the details is like how you lose, and I don't want to lose for you. Michelle says, I had severe heat intolerance for 5 years. So severe that I literally haven't been able to step foot outside in the summer. Transdermal estradiol completely alleviated the heat intolerance. It's great to hear. I'm curious to hear if it helped everything else or if that was the only problem or what's going on, but I'm super happy that worked for you. Matheson said, can sympathetic overdrive cause neuropathy in the arms and legs? I used to have lightning sensations when I got startled, but then it became chronic low level of the quote lightning. But functional medicine doctor tells me it's inflammation. Like a lightning type of a sensation for someone, if you've ever had one, kind of implies that we have a rapid on-off. And if we have a rapid on-off, that's not the time course for how things work when they're inflamed. Those are things that tend to look more like things where we see with Laramite sign, where we see these little flashes, like if you hit your funny bone and kind of shoots down your arm and makes you like that, or you hit the nerves in your wrist and they kind of send it into your fingertips. These are more related to when we put external pressure on nervous tissue, particularly in the spinal cord, if we're getting it down the shoulders and in the arms or into the legs, or sometimes in the peripheral nerves themselves. So whether or not that's from a sympathetic overdrive, I don't know. But when I think about the sensation of electricity or lightning that's coming through the system, and especially if it's happening in shocking moments or with movement, then we would think about looking up the Laramite sign as a more, that might be a more fitting framework to think about that in. But maybe not. It might just be worth checking out. Cool. Sandra says hello to everyone. Hello, Sandra. Okay, sorry, I'm just catching up here a little bit. Okay, let's see. Back, Michelle, I think maybe this is a continuation. Curious if decades of cerebral hypoperfusion can lead to microvascular ischemic changes of the brain's white matter. Yeah, so these are little, they call them lacunar infarcts typically. We see these little white matter lesions. They'll comment on them usually in an MRI. And that's a lot of what you're looking at is usually levels of hypoperfusion that end up causing kind of like a scarring into the microvasculature. Yeah, absolutely. Lakeisha says, can patients recover from small fiber neuropathy and related pooling? Certainly available. And then the next question is like, based on, like who can, and then that's whatever the problem is that's causing small fiber neuropathy. You got to pull that out and then let that stuff heal up. But can they recover? Absolutely. See it constantly. So go get them. Let's go get it done. Corey, what's your take on Diamox for people with issues with pressure? It's a long-term thing or more of a short-term temporary Band-Aid? So what Corey's asking about here is going back to talking about the barometric pressure response. So Diamox can be used, it's typically used for people with intracranial hypertension. And it functions loosely as like a diuretic. So it allows some of that fluid drain off so that you are able to decrease the hypertension, which can be really useful for people. A lot of times you can get it prescribed for people that are going up in the mountains that get altitude sickness, and they'll actually prescribe it. Well, I say they'll prescribe it. People will go to the doctor, and at times they will prescribe it, usually in short terms of like 2 weeks, for people that are traveling in the mountains for altitude sickness, and it can be helpful for that. And that's one of the things people will do. I've had a lot of people seek that out. We facilitated that for people with their prescribing doctors, and it can be really helpful. I think as far as like the term of that is going to be usually relative to kind of a short term or a Band-Aid approach. There's a give and take because you're just artificially changing a pressure response that your brain thinks should be there or is not able to adapt to. So again, this kind of comes back to some of the philosophy about how you solve a problem. If you're a person that is like, I just want to take a thing and then like pretend it doesn't exist anymore, then you're going to probably like the medication. If you're a person that's like, I know there's still a problem underneath there, I know I'm making a trade, I'd like to solve the underlying problem, then you'd probably look at that as like a short-term type of a Band-Aid. But it can be, especially people traveling, a lot of people will use that. especially going like Texas, Colorado, something like that might be a reason to do that. Cool. All right, Amanda says it was a very long. Oh, okay. So Amanda had asked a question earlier about having worse symptoms present after surgery. Long surgery, removing a cyst in the fourth ventricle. I think I remember you telling me that. I'm sure it wasn't positioned beautifully. How do I find out if something during surgery messed me up to possibly reverse it? So the other thing to consider here is the fourth ventricle. If you ever get out your, I don't know if I have a picture of it pulled up, but if you ever get out just an atlas and look at that, where that's at in the brain, you realize that the fourth ventricle basically forms the back wall of that medullary area where all that autonomic stuff is happening. So this is actually a case where messing around in that fourth ventricle, if we're still getting inflammation in there, back to our question from, I think it was Matheson, if we're still getting inflamed in the back of that area, or there's irritation or something happened during surgery, then that autonomic system can be a big part of recovery. I think there is another young lady on this stream that is a great friend who went through something not the same but similar, and noted that there was a recovery period in that, and we worked really hard basically rebuilding some of those functions again that had dipped after getting that surgery. So I definitely know what you mean there. With it being in the fourth ventricle, that may be more likely for someone, I don't know without looking at it, can't give medical advice, but we have seen cases where we've had to think about that brain surgery, think about how do we want to get that stronger again, rehab that again, kind of like you would after a stroke. How do we strengthen that back up again and get you back toward normal? So yeah, I'm thinking about a very specific person and how to relate that for you, but I don't want to reveal her identity, so we'll leave it there. Susan B, what is the relationship between muscle tension and high blood pressure? Had a surge of 160 over 109 in a stressful environment. Felt like I had a girdle on. Couldn't expand my diaphragm to breathe. So, that's very interesting. If we're in that high stress environment and everything's tensing up and it's hard to breathe, you can get, that can definitely happen. These can be things that happen more in acute responses to stress, acute responses to anxiety, panic, those sorts of events. Those are more common. So where you'd want to go from there is knowing, like, is it something that happens a lot? Is it consistent? Can you reproduce it? Or does it just happen in that context where it is really stressful? And then understanding that part of the stress response for you is actually probably where to start from. But the stress portion probably matters, like the size or the amplitude of the reaction to that stress. Okay, we got Ama's back. POTS-like symptoms came after hurting my neck. Thoracic outlet has been ruled out along with any neurological cardiac immune disorders. Could a misalignment in pinched nerve in the neck cause so many symptoms? It can. Certainly can, but I have no way to know if that's exactly what the cause is or not. And I would want to look at like a whole host of other things with that before we could prove it out. But glad you got that workup so far. Could it be a misalignment? It could, but you can also measure that. So you don't have to guess at it. You just want to find somebody that can measure it. Cool. So that would be probably next step. Sandra, I see your question about muscle contractions in dysautonomia, but I'm not sure what that means. Peace, love, mung bean. Does cerebral hypoperfusion cause PEM crashes, so post-exertional malaise crashes in patients with ME/CFS? Why is POTS so common in myalgia encephalitis? It's a great question. So there seems to be a lot of evidence in like PubMed literature that shows a correlation between the way people experience post-exertional malaise and the relationship with hypoperfusion. That's also a thing that we observe clinically, that those two things are very much related, and so much so related that we can kind of see in the exertion phase where the hypoperfusion comes in, we can kind of start to predict where that's going to be problematic. Why is it so common? I think POTS is so common in these types of problems because of that overlap with perfusion. One of the things that I draw a pretty hard line on from my experience is looking at people that have like a very true POTS in terms of like it is POTS that's not being caused by something that's obvious, in their normal sequela of things that to rule out. And they're kind of left in that POTS world. There's such a huge component of that POTS being the representation of your body trying to fix hypoperfusion that it's hard to deny it. It's hard to ignore it. And then you see the overlap. So people that have ME/CFS, we're really talking about the same thing in a lot of ways. We're just looking at, it's just a nomenclature, it's naming, and who's the person that's naming what's going on for you will have a big effect on which diagnosis you get. So I think that they are very common in the fact that they both are relative to cerebral hypoperfusion, and then the compensation to that is going to be an increase in heart rate. It has to be. If you can't compensate with a higher heart rate or stabilizing your blood pressure, then eventually the blood pressure is going to drop to the point where you pass out. So that is going to be what your body is going to do. It's going to amp you up. It's going to increase your heart rate. It's going to try to push your blood pressure. It's going to try to do whatever it can to keep you upright. And I really think that we have to look at it that way. And when you do, it becomes way less scary. It becomes more transparent about what needs to be done from here. And it gives people a lot more options outside of just manipulating their biochemistry in ways to solve it. And I know that feels frank, or maybe it just feels frank to me, but because I equivocate on some of these things, but like, that's what we got to pay attention to that. Like, there's so many people that this is the fight they're fighting. No one's talking about it. No one's doing anything about it in cases where like, there's a lot that can be done about it. So let's do it, sorry if that's frank, but that's the way I feel. It's like, so many of you, this is a problem you're dealing with, and like, we should be solving it. What's getting in our way? I feel like the biggest problem is just like, it's not patients' fault. It's they don't know. It's you guys don't know. We're trying to get to a point where can we improve the education on this enough to where it becomes obvious to everyone else the way that it is obvious to me that these are the problems. These are a huge portion of the problems we have to solve. They're not everybody's problem, but this is a big problem we got to solve. Okay. Sorry, that got a little ranty. That's what it says. Thanks for answering my questions. I will be sure to search your channel for more info. Oh, that would be very nice. We really like it when people come to the channel. If you want to hit a couple likes, maybe some subscribes, that feels really nice to us. That'd be great. Dr. Ginia gets a big smile from that too. Really appreciate it. John, I like this. I feel like I'm at the very end of POTS, which is really awesome. That means we're getting improvements. You're doing great. I love hearing that. I still experience some dizziness if I move too quickly. Is this an expected symptom? It can be. It can be expected depending on what's causing it. So a lot of our people that have challenges in the vestibular system, this will be a thing that they notice where like that quick head movement, they get the lag or that VOR isn't working, may have some insight into why some of those systems are still lagging. Be curious to know what kind of dizziness it is. Dizziness is a tough word, but so that might just give you the next avenue to kind of go down to see if you can just push that whole thing right over the ledge. That'd be awesome. All right. Fatima says, question. My doctor was recommended that I should be in an IV therapy twice a week. Any suggestions? My suggestion, IV therapy is a great way if we're just doing like banana bags. It's just a way to push blood volume up. It's like a very lazy way to just say we're going to slam you with more blood volume and then kind of ignore anything else that's underlying it. I'm apparently in that kind of a mood today. So, I mean, you can do it. You will feel, but like most people will feel better with an IV, just in general. We know that. That's even been researched, right? So even just healthy, normal people, you give them an IV, woo, we're doing great. it's reasonable to expect that if you got somebody that's hypoperfused, you give them some more blood volume, they can get a little bit more juice going, great. But if you got kidneys or sensors that are worth a darn, then you're just gonna load those up. You're gonna have to urinate a lot more. You're gonna have to balance out the electrolyte system in the body, and you just rinse and repeat, and you'll just do that. The danger of it has always been considered, like, if you do that, then you get your body used to using that as a source of hydration and stabilization. That's not great. And then another paper comes along and says, well, maybe it's not that bad, but at the end of the day, you're still doing IVs twice a week and not solving any problems. So again, this goes back to the treatment philosophy of whether or not you want to solve the problem, or if you're happy to do kind of like these adaptation devices to be able to kind of limp through. And that's just like a personal choice. I can't make that choice. I know what I prefer, but like, it's not up to me to make that call for anybody. If it gets you out of pain or it makes you feel a little bit better, who am I to stand in the way of that? I just try to lean toward, my tendency is to lean toward solving the problem. So that's the general bias I have. So if you can kind of deal with that with the way I speak, then you'll know that that's what I feel. John said, I was experiencing POTS symptoms. I feel like they are mostly cleared at the moment, except for hypersensitivity, either bright light or loud environment. Should I be worried for anything else? So we've got some delay when you move. We got some light and sound. Sounds like we got still like a little bit of bandwidth processing component to that, but it'd be worth probably wherever you're at locally seeing if you can dive into that and push it, like we said before, push it over the edge. Sarah asks, what causes a movement sensitivity? I can't watch horizontal or vertical movements or experience movement myself. Like example would be like a rocking chair. Okay, this takes us back to a lot of what we usually talk about when we're talking about concussions and post-concussion disorders, where the ability to onboard that input is overwhelming. And it can be because your brain can't process the volume, like the amount. So that amount of movement feels like too much, and it's just kind of like you hit capacity really fast. Or it can be that the way your brain is processing it is skewed, and it causes a mismatch with other systems that makes it feel like it is not accurate, which can make you sometimes feel nauseous or dizzy or headachy or disconnected, any of those things. Much of this is related to the visual vestibular system, especially if it's both when you are moving and when things are moving around you separately. Both of those things are affected, and we want to look at where that information is integrated. That's that good old-fashioned functional neurology coupling with concussion experience, looking at optokinetic responses, vestibulocular responses, cervicogenic responses, and looking at how all those things meld together and try to build them back up again. That's the thing that can be done like very expertly. You just have to find the right people to walk you through that, but that is definitely a thing that can be solved for. So good luck with it. Hopefully that kind of leads you down answering the next questions down the line. Susu, since I've started taking creatine, I feel like my post-COVID brain fog, post-exertional malaise, and POTS symptoms seem a little better. Is there a known connection with creatine? So creatine allows for just a little bit of extra storage of energy in the brain. Can't get much, but it is there. So it's a thing that's been known. People have been doing it in concussion for quite a while. And it can help with a little bit of that cognitive component, just taking a little bit of the edge off. So for a lot of people, there's not much harm in that. It's part of a normal dietary component. You're just able to kind of like hyper load into that system. One of the questions we talked about, we get in debates a lot, right? Because it's fun. And one of the debates is if you're taking it exogenously, could you also get the same thing by eating more creatine-rich foods, meats, eggs, things like that would allow you to dietarily load it in? And so that is one question, is like, was the diet going in sufficient in terms of creatine? Maybe there's a way to not just get the creatine out of it, but actually shift the diet in that way so you get all the other benefits, fats, cholines, things like that would come with it as well. Those can be helpful versus taking the supplemental. But either way, I'm really glad to hear that it's going well. It's a useful tool. There's not much downside to it. So that's one that's become super popular, especially in the last couple of years. Okay, so we're getting now back to, so we're at Amanda, and this is probably from the beginning of the stream when she says, I love your marathon analogy for Ash. When she crashed after 12 hours, why can you push through symptoms sometimes with later consequences of crashing and other times have symptoms immediately? That's a great question. And that's kind of like a function of bandwidth and the irritation within the system. I look at it in terms of like, are we running out of gas right now versus is the system that is in charge of recovering not strong enough yet to like fully charge that battery in the amount of downtime you have. So people where the problem is like in the here and now and we overwhelm the system and we get the symptomatic expression, those can happen right now acutely. Sometimes though, you've got enough gas in the tank to do the activities, but we don't have enough strength within the recovery portion. And we forget about that. Like used to be easy for me to forget about that. But the recovery portion is also active. That's not like when you go to sleep at night, we don't just like kind of like die for a little bit and then wake up again. It's a very active process where your brain is doing work to be able to do the recovery. So if it's not able to do all of that recovery in that period of time, then we may find that when you wake up, then we may not feel as well. We may have like that malaise. So it's another way to think about this that I talk about with my kids is when they go to bed at night, they can be wired and feel like life is so great. How many of you guys have felt that where you're like, I feel great going to bed tonight, but it's way late and I'm only gonna get like 5 hours of sleep, but I feel amazing right now. But then you wake up and you're like, I got hit by a bus. How did I go from feeling great 5 hours ago to feeling like I got hit by a bus right now? Is because I wasn't able to get all that recovery in, and now my body is like, oh, you kind of like stopped me mid-phase here, man, you're killing me. So that can be a way to think about the difference between like a post-exertional component versus an acute response. Also, the post-exertional component can come with inflammatory mediators that aren't able to clear out in that time frame as well. So just different ways to look at that. Good questions. All right. Dr. Genia's got one coming in from the Instagram. She says, how do you handle patients that come in with craniocervical instability? Well, a couple things. Number one is, to what extent do we have the instability? What is the origin of that instability? So it's not all created equal. Not every, like you don't, it's not a 1 or a 0. It's a continuum. So is that instability, what plane is it in? Where is it at? Is it specifically within the upper cervical vertebrae, or are we seeing it transmit down into lower areas? Is it a compensation for rigidity in other parts of the neck and back? So if I have hypomobility or rigidity in my, call it my like shoulder area, the top of my thoracic spine and the bottom of my cervical spine, I can start to create an adaptive instability or hypermobility in those areas to allow me to move my head to make up for immobility in lower areas. This is well studied, really good paper on that. And so at that point, you're trying to determine also, is this from an injury? Is this something that somebody was born with? What's going on? And to what degree is it amenable? So does it respond to being able to improve the coordination of the muscles and joints around it so that we can stabilize? Or are we hypotonic, where I don't control my muscles very well, and that allows me to get into those really far ranges of motion that then cause problems because I'm in too deep of a range of motion? So think about that. It makes me think about a case of someone that had a car accident, right? So in that car accident, had an injury to the neck. And that injury to the neck meant that she could, in this lateral bending, the lateral masses of her C1 would slide way over, and she's got this alar ligament laxity. Okay, so tried doing prolo, that didn't work. Tried doing some PT, that didn't work. okay, so what are you going to do? You can't just say like, well, that's it, away you go. So what we did in that case was we say, okay, well, if that alar ligament isn't working effectively, number one, can we do things that muscle is going to be more responsive so that I'm quicker to respond and it doesn't allow that bone to just flail around like one of those air people dancing at a used car dealership, right? So if we can improve the control systems around the neck, then there are less frequent opportunities to be able to exceed that threshold and cause the symptoms that's related to the neck going too far, compressing things, irritating the spinal cord, etc. Can we get that control system in? And for so many people, that's viable. That's a very reasonable thing. And a lot of those people also have problems where that instability is an adaptation for rigidity somewhere else. So being able to combine and think about it in those ways helps to open up some more insight for people that maybe feel like they're running out of options in other ways. Cool. Okay, so next question here. I've gained a lot of clarity and insight from your shorts. Kudos to your editor. There you go. You're welcome. Can you discuss how emotional moments trigger physiological events like brain or body naps or seizures? Okay, so how do emotional events trigger them? So remember, this is kind of like the fainting goat analogy, right? So you've heard of a fainting goat, you scare a goat, and it tips over and it like takes a nap or falls asleep, right? So those startle responses, same thing, you sneak up on somebody, they jump up, they startle, they get mad at you, take a swing maybe, who knows. So these are all usually emotions these are in this case startling, but startling can also be things that are highly emotional, usually make you sad, make you angry, but they can also be things that make you surprised or make you anxious. So for some people, even just being surprised or happy or anticipating an event can lead to these things where we get an over-arousal, and that over-arousal in the system can have multiple effects. It can make it so that we increase resistance in vasculature, which can cause ischemia, where we can get people with like hemiplegic migraines, or they can't talk, or they can't see, something like that. Or we can have them where they actually create a spreading depression in the brain and they actually do become seizures, and that's a common thing. Other ones that are more considered psychogenic or non-epileptiform types can happen with emotional events simply from activation of the midbrain arousal systems and how that gets projected into the limbic areas as well. So there's a lot of nuance in that in terms of how they can be caused, but they certainly can be triggered. Emotions are really important sensory and interpretation moments in the brain. We all have them. We all experience them at different levels and different rates during different contexts. And that's kind of what we're looking at here, is to what degree those contexts yield that physical response. So just the same way someone would be really hard to startle, and then other people, if you like snap your fingers, they jump and leave the floor, right? So that continuum of startle, if you think about that, you can think about applying that into what you're talking about, where we go into either epileptic or non-epileptic seizures, or seizure-like events where we yield this bigger response than we would typically be used to. Melissa, hola! Good to see you. Glad to see you on tonight. Lucila, my last tilt test was normal under Florinef, Mestinon, and high thigh compression in a cool room, but, well, so if it's normal with all of those things, that's a lot of gear that we've got on here, so we're not really getting a real look at what your body's doing in that scenario. In the heat at home, low blood pressure and heart rates over 120 standing. Can heat alone cause this despite meds? So are you wearing the thigh high compression here, and were you on the Florinef and Mestinon? Are you walking around versus being on a tilt? I'm not sure why we do the tilt test with all of those meds. because you can't really say it's normal because you're on all the meds. And then also we don't know what the tilt looks like in terms of cerebral blood flow. We don't know how that relates with the Valsalva deep breathing responses as well. Can heat alone cause these things? Heat is the great puller of blood to the skin. It's going to take it out of the circulation. So yeah, it can be a trigger for it. It may not be causal, and that may not be the underlying problem, but it can be a trigger for a lot of people because it's pulling that blood out of the central circulation. That's the take-home event, is if I do something that pulls out of that budget that you're already just duct taping together with like a lot of work here, then you see where the system breaks down. JS Genesis Designs. Question. So if I have unexplained syncope, the first event caused a false EKG reading stating that I was in cardiac failure, later to find out I wasn't, but then passed out again, found out I have scoliosis in my neck. Let me make sure is at the end of that question. Maybe so. So the question there is, when I got to the whole question, so the context of it is unexplained syncope. We got a false EKG reading for cardiac failure. Later, maybe that's not true. Passed out again. Scoliosis in the neck. Sounds like a good bit more of investigating would be a good idea to see what's going on. If we actually are having EKG readings, if we're having heart rate drops, if we're having blood pressure drops. What's going on here? Lot to dig in on, which is a good thing. Lots to dig in on is a good thing because it means there's a lot of opportunity to figure things out. So I don't look at that as a bad thing, not having the info. Just makes it a lot more helpful to be able to figure it out. Cool. All right. Okay, and Irene, coming back to our question from earlier about blood pressure 90 being the systolic number, I don't know that helps us get super far without the diastolic number and stuff. But I also don't want to get in the habit of trying to answer. I don't want to try to answer this as a question through the chat, trying to do a diagnosis through the chat. Okay. All right. Where are we at here? I gotta get a drink of water, so we'll take a little breather intermission. Melissa, let's sing a song. Okay, so we're at about 9:30. We'll go about another half hour. I'll go through as much as I can. You guys are super great. Great questions. I wish I could answer some of them. So it's hard sometimes because I'm trying to answer them. I want to give you great answers, but some of them also I'm limited by. Don't take it personally if I say like there's not enough information here or I can't diagnose it through the chat, because legally we can't do that. But then also morally, I'm not going to win a lot of those because there would be a way high probability. So if like you were like gunpoint, hey, you got to solve this through chat, that would be a bad strategy. I probably wouldn't be nearly as good at that. But when we get like a deep look at things and we get a lot of data, then it's way easier to be able to make a more refined decision. So I don't want to sound like I'm waving anybody off or anything like that. It's nothing to do with that. I appreciate the questions. I try to find a way to answer them in between if possible. So please don't take that personally if I say like I can't answer it through the chat. That's not what I mean by it. I don't want to miss. It's also just not legal, and so we shouldn't do that. And also I want the best for you guys, which would mean I don't want to take a guess at anything that could lead you to make a decision that isn't the right decision because we just didn't do the work right. So that's what I mean by that. There's nothing more than that. Okay. Heidi says she's late, gonna have to restart and watch later. Awesome. I hope that maybe you can even watch it at fast speed and see if you can, I don't know, maybe I talk fast, maybe I don't. See if we can catch up to that. No man over normal. Hello. Any exercises or things to consider for improving cognitive processing speed and executive functioning? Good question. So first things to consider in this room would be, are we getting juice to the head? Are we getting blood flow in there? If we don't, all bets are off in terms of exercise because we got to be able to feed the system. So we're going to make the assumption that that is intact. And if that is intact, then we want to do things that strain or stress cognitive processing. Easiest way to think about that is, what are the things that are giving you a hard time? And how can you start to, if you're trying to get to here on them, where can we start where you can start doing that cognitive loading in a way where you can build up steam again, the same as if we were running our marathon. So for example, if you're trying to get to where you can do more of your work, number one, you want to set yourself up to have the least amount of friction to doing that work as possible. So the least number of things that would be irritating. Try to strip as much of that away as you can. And then be able to do just the task and try to do that as long as you can before it starts to feel like you're failing. And as soon as it starts to feel like you're failing a little bit, then you rest. So you just push up to that point, rest. And then we come back, try to push a little bit more, try to push a little bit more, try to push a little bit more. And so that is how I would think about it in a large function. When you think about executive functionality, it's kind of a combination of two things. You have to have attention, so you have to be able to pay attention to something, and then you have to be able to have memory. And if you can do those two things, that's the core of executive function. So if we're trying to improve that, that's what we want to work on, is two things that we are improving: attention, our ability to stay locked in on a thing. And then second would be our ability to do short-term memory conversion. So here's where memory games come in, all sorts. Sudoku, flipping cards, end-back tests, but then also doing things that are motor with that. So being able to use your body while you're doing them, playing different games, being able to use eye movements. We use a lot of eye movement strategies to help be assistive in that, and we will bias one side versus the other. Do we want to bias the sensory system more than the motor system? How do we want to think about those things? And we'll start. When I do that, I want to tie those things together to try to create a more targeted approach for that particular person's brain. But if we think about it just writ large, things that make you pay attention and use your memory are going to be like the kind of the core feature of that. So games that do that, your work that does that, conversations that do that, even if it's just like talking to ChatGPT and just like having conversations about things that are interesting that allow you to be able to have to focus, pay attention, listen to what's going on, and be able to execute functionality from there. That's a great place to start, pretty much for anybody. That's where I would start from a conceptual level, and then the more tools and tricks you have with that, the more you can take that concept and make it sing. All right, Tara says, my 13-year-old daughter has been passing out multiple times a week since October. I'm sorry to hear that. She's been seeing a cardiologist, and it's not her heart. That's great. Her diagnosis currently is vasovagal syncope. Any suggestions? I'm at a loss. So suggestions here, if it's vasovagal syncope, we're looking at, is it bradycardic? So is the heart rate slowing? Is the blood pressure slowing? Are both happening while she's passing out? And then we want to look at, if it's not in the heart, great. What is the connection between the brain and the heart that we're missing here? So is this a problem with NTS integration, cardiovagal output, baroreceptor systems, problems in the RVLM, problems in the CVLM, problems in downward in descending outputs from the midbrain? I know all of that stuff is gobbledygook because it doesn't mean anything in your position, but by understanding them, it helps to figure out why we're not getting that signal that's coming down, or we're not getting the inhibition and we get too aggressive of a stimulus that's coming to suppress activity of the heart. And if we're getting an over-aggressive stimulus in that way, then we want to be able to boost the things that would inhibit it. So depending on where you are, you may be able to get someone near you that could walk you through that. Obviously, we're here. I don't know where you live or what that trip looks like for you, but hopefully we can get some help for your daughter. Okay. Okay. From Sandra, I've seen this question a couple times come through, but I don't know how to answer it because I don't really understand the question very well. Why would muscle contractions in the neck and other areas of the body worsen after eating if you have dysautonomia? I need to know more about, is that like a static contraction? Is there a duration to that? Are they segmental? Are they in regions? There's so much there that I don't have a good way to answer that without knowing more. If we're having muscle so the first part of it is if we're having muscle contractions that are occurring out of context and non-volitionally, then we have a movement disorder. Then we're just looking at how that movement disorder is relating to the other movement disorder that is dysautonomia, which is a vascular movement disorder typically, but can also be a GI movement disorder. That's what gastroparesis is. So these are all just different types of movement disorders, but I don't know how to classify them without knowing a little bit more about the phenomenology. Usually to know that you got to see it. So I don't know that it's good to answer that here because I don't have anybody to see it and really give you a sense of what that would look like. Heidi says, do you believe in chiropractic work for headaches? I'm a chiropractor, so I do tend to, I don't know if it's more of a belief structure, but can it work for headaches? Yeah, depending on the headache, it can be super great. There are a lot of people that get a ton of relief from that. It's probably worth checking out. So if you haven't done that, or if you're like trying to tiptoe into it, probably not bad to at least like get a sense of maybe what's going on from a different perspective in terms of chiropractic. That might be useful for you. Dana Bear, I wanted to come into the clinic, but ended up being led down the road of pheochromocytoma by my doctor. Are the episodes with hyperadrenergic POTS and ones associated with adrenal crisis comparable? Well, if you got a pheochromocytoma, then you'll know. I mean, you can test for that. You can look at plasma metanephrines. You can do an ultrasound. You can see if it's there. And then usually what they'll suggest is removal. So if that's what it is, then that's what it is. Are they similar to hyperadrenergic POTS? Sometimes, but it kind of, I mean, yes and no. So in a pheochromocytoma, you're releasing adrenaline or epinephrine, whereas when you're looking at feedback loop errors within sympathetic nerves, we're seeing a rise in norepinephrine, which is the signaling mechanism within sympathetic nerves. So one is like just an excess feedback loop where it's just cranking too hard. And the other one is where pheochromocytoma, for those of you that I just completely didn't define that for, the pheo is an adrenal gland tumor. So we can just get exogenous or just like random release of epinephrine into the body. So it's just like juicing you all the time, and it can make everything exacerbated. So they're just like they're a little bit different in terms of their outcomes. If they feel the same, I don't know. I've never felt what one feels like, but can they be similar to an adrenal crisis? When I hear adrenal crisis isn't a specific diagnosis, but it makes it sound like it's not working well. Usually we'd think about that as being a drop in functionality, where we actually might experience probably the opposite of what you experience with a tumor, where you have just too much output. So you're looking at hyper versus hypokinetic outputs of the tumor. Okay. I hope you get that. Yeah, I hope you get that fixed up, get that taken care of, and get that knocked out. See if we can get those episodes to come down. Okay. Oh boy. I'm not sure what that one is, ST. Okay, I says, love your work. Nice to see family visiting dad. That's one of my favorite parts of the night. Sandra asked, have you seen peripheral neuropathy and dysautonomia together? All the time. That's part of the same function. We call that typically neuropathic. And what you're looking at is the difference between, in the autonomic system, dysautonomia implies that there's a problem within the autonomic nervous system. Traditionally, the autonomic nervous system are peripheral nerves that come from your spinal cord into some degree your brainstem and travel out into the body and control autonomic outputs. There's also a central autonomic system that basically is the brain processing system that takes in information, processes it, and then spits out an output to the peripheral autonomic nervous system, right? So we've got a central autonomic nervous system and a peripheral autonomic nervous system. In dysautonomia, we don't really differentiate between those two systems very much. So if there is a dysautonomia where my autonomic nervous system is impaired, then we're looking at that as being either a problem in the central autonomic system or in the peripheral autonomic system. So if we have a peripheral neuropathy, which is a problem with peripheral nerves, those can overlap or be part of a dysautonomia that's a peripheral dysautonomia, if that makes sense. Also, where we can see additional, like a nuance of that, another layer, is the peripheral nerves, remember the sensory nerves, also are informing the central autonomic system and its outputs back out to the system. So even if we have sensory problems that aren't necessarily autonomic problems, those signals do go to the central autonomic system, the central autonomic system in the brain that creates the outputs of the autonomic nervous system in the periphery. Okay. All right, Christy Lee asks, can video games be harmful to someone with dysautonomia, or can they have benefits too? I don't think this is an either or. I think it's a yes and. I think in excess, people will probably experience problems with video games, maybe not just on the neurological side, although the extreme amount of blue light does have different effects in the autonomic system and in the metabolic systems. But also they can just have like behavioral consequences to that. But sometimes they can also be a way to create cognitive loading, to be able to give tasks and puzzles just like other games would, just like a board game would. The difference is just kind of the light response that you're dealing with and the intensity of that response. And the other component that we talked about this week was that they can also be used, it's like a tool, so you're projecting your brain into another arena or into another character that allows you to be able to kind of separate and use the supplementary motor area as though it's a tool. And in some ways that helps us differentiate from our body, especially if we're hyper arousal type person, we're a little vigilant. It can help us move outside of that. And there's also kind of like a hypnotic component to playing video games sometimes that allows us to change state of the brain waves and allow us to be able to kind of hit a rhythm that can be calming for some people too. So writ large, like I generally tend toward not using a lot of screen time, especially for my kids, myself. But the give and take of that is it allows you to access sometimes a community in gaming that allows you to be able to stimulate your brain in some different ways that can be functional if not overdone. So I think that's a really good question. It does have some nuance to it. It's a both scenario. So as long as we're using the tools really well, they can be a useful tool for people that are dealing with brain-related problems. Okay. Colson wants to know, coming back to the oxidative stress component, can the brain recover from damage due to oxidative stress? Absolutely. We are always undergoing oxidative stress. That's actually part of the utility of the brain. Yeah, you're not going to get rid of it. It's always there. And it's also probably not the thing to be the most worried about. If that's what you're noticing, that's giving you a lot of fear, then you can probably have some solace in knowing that like oxidative stress is part of the normal environment in the brain. You don't want to have too much and create these big problems, but it's part of what we're meant to deal with. It's part of how our metabolic system works. Okay, so Amma says cardiac neurological TOS, kind of going back to what she was talking about earlier. Sounds like we need to just get a little bit bigger workup and get people that are on it. So I'd love to help. All right, Julian He's saying, hey, what's good? I like that. Thank you. Yeah, this is what I get afraid of when somebody's like, hey, I did transdermal estradiol and it worked for me. But you're also like giving zero context about anything else in your life. And like there's testing involved that decides whether or not you should use estradiol creams. Usually estradiol is not the cream you use, to be honest with you. So when people start asking like, oh, I haven't been able to step outside and estradiol is going to fix it all, probably not. Like that happened to solve the problem that she had. A lot of the people on the stream are going to be heat intolerant. What I would like to avoid is stuff like this where people are like, well, I'm going to try that because it worked for you. That is not a reason to try it. It is maybe a reason to get your Dutch test run and look at your hormones and see what's going on, but don't jump just to that as a conclusion that you should do it too. That's how people get themselves in trouble. Okay. Danielle, it's the same thing. So positive comments on extra pots and creatine use. Yeah, little bit of extra energy. What it probably is speaking to is kind of what your current diet looks like, to be honest. And it may be a signal that we need to change up a little bit of the diet so that you're able to onboard a little more of that creatine and use it. And Michelle, also me saying that doesn't mean that nothing against you at all for sharing that. I'm glad you shared it, but I also don't want to create an environment where we just like try stuff because you work for somebody else. You want to take that in and say, well, how can I figure out if that would be relative to me? Do I need to do some testing to figure out if my estrogen levels are normal or not, and then work from there. Melissa, I've been looking into a low intensity vibration plate for my mom's osteoporosis. Nice. And seeing the multiple benefits, wondering if that might actually be helpful for someone like me too. Okay, so how do you do this? So I know a little bit about this, right? So I love that it's helping with the osteoporosis. You may find if we're having cervicogenic proprioceptive error, it may amplify that by adding another higher frequency to it. So with the sense of motion and with the cervical proprioception component, you want to make sure that you don't do it too much and exacerbate that or amplify that discrepancy between those two types of motions that you're feeling. And I know I'm getting like very specific for you, but I think you know what I mean. Okay. Julian, joint health tips. I know it doesn't seem serious, but it is if you can't work out. Very true. Joint health, writ large, like that's a lot. So are they inflammatory? Are we degenerative? Are they sore? Are they achy? Are they stiff? Obviously, motion is lotion when it comes to movement. Also, just using topicals can be useful for some people. Addressing immunological problems, diet can be a big thing. Lots of opportunity to intervene there. Again, I'm probably missing a load of things because that's a big boat. Okay. Switz is asking about estradiol, wondering if premenopause of some sort, having hot flashes. So I'm sorry if I'm totally off of that since I don't know your age. Yeah, I think these are the right questions to ask, and that's investigating. I like that. Investigating some of the causality underneath it that leads you down the road that can be way more useful. And Mathieson said, I just want to ask again because I didn't word it well before. If there's a constant low buzzing sensation in the lower arms and legs, could it be from inflammation? Inflammation in terms, I don't like using the term inflammation. What you're really asking is if it's from neuropathy. If it's from neuropathy and you're getting a buzzing in the legs and arms, then you want to test the quality of the nerves. So do they respond normally to vibration? Do they respond normally to light touch? Do they respond normally to pinprick sensation, temperature? And then that's going to give you an idea of how well the nerves are working. If you're feeling something that feels like electricity, you're feeling something in the nervous system. So you want to know, like, do the nerves work? And then you can walk your way back to, like, is it inflammation? But what would the inflammation be there from? What's it trying to heal? So are we feeling like we've got a hyperactive immune system? Do we feel like it's something like a Guillain-Barré that's affecting the nerves? Do you feeling, so like there's nuance in that. Inflammation, I want to get away from using the word inflammation simply because it becomes like a non-tangible word for a lot of people. He said even though it originally started as lightning sensation, now it's more or less a low level of tingling and fatigue at a constant level. So this is where, looking at the quality of the nerve. Then you can back out and look at muscle responses. Do we have any loss in strength, any loss in reflexes, any loss in muscle endurance? Are we looking at claudication that's happening? Is the arterial supply, the pulses, are they normal going in? Are we having venous changes trying to get it out? Are we having pooling? Are we having blockages? You just got to work through all those things. And a lot of times if you're having inflammation, if there's not a local tissue injury, then what you're saying is like something in this system isn't working right, whether it's inflamed or not. Kind of we start to lose its value and just start targeting what could be causing that sensation and coming back from there. Yeah, so I think you guys are we're on a side quest with talking about estrogen and asking about the hypothalamus and estrogen. Using estradiol cream is important because to understand this, you got to go way deeper than just thinking about estrogen writ large. You're thinking about estrogen, estriol, estradiol, which are the metabolic, they're different levels of conjugation. So it's like how if your body's used it and it's trying to process it through the liver, maybe that's the easiest way to say it, it's going to change that functionality. And the quality of being able to process that through the blood and the liver is going to allow you to be able to excrete it in a normal way. And a lot of times you'll have buildups, which can cause changes in signaling mechanisms. You can have alterations in estrogen relative to follicular stimulating hormone or to luteinizing hormone. So you end up like kind of in this bigger nuance than just the estrogen itself, particularly if you're looking at an estradiol cream, which is an interesting choice. So I'm not going to get super into that because asking about that in the hypothalamus, we're going 2 levels deep there and talking about it as a signaling mechanism from the hypothalamus, which just should run on that circadian monthly biology, right? So if you're healthy and doing great, it's on the month, just like clockwork, and everything works pretty normally. If that signaling starts to break down, that neurogenic signaling can come from the hypothalamus, or we can have problems in that hormonal loop where we're not signaling kind of the next stage in the process effectively, and that can change the circadian rhythm as well. Okay, we're going to wind down here soon. Question from Josh on Instagram was, how long does a typical POTS recovery take once coming into the clinic? I don't have a good answer for that and the main reason is it's so stinking different. So POTS, number one, a lot of different causes. You walk into the clinic today, you're going to see a lot of people with POTS and very few of them have the same problem. And if that's true, then you're not trying to solve the same problem for everyone. Then you're not having it's not going to be the same outcome time frame. It's also not going to be the same outcome time frame based on age, based on gender, based on how long it's been happening, how much function we've lost versus how much you've maintained. And then also like big portions of it are motivation. How attentive to detail are you? How persistent are you at doing exercise? Like all of those factors matter. I think the better way to look at it is like how quickly can we start to see things change and move in a positive direction. It can be very fast, in the order of weeks, days. So you can see things start to change pretty quickly in a lot of folks. And also, it's hard to know the pace at which someone will learn. It makes me think about watching my kids grow up playing sports. You can take kids, they're all playing t-ball for the first time. Some of those kids just can naturally rip the ball. Their swing looks good. No one taught them anything, right? My 8-year-old, my daughter is like that. Like with no effort, she's just good at it to start with. Whereas other people, you like pull your hair out trying to get every movement right, and it's so mechanical and awkward, and they have a really hard time learning it and onboarding it. Does it mean that they can't ever hit? No, it just takes a different amount of work to be able to groove that brain, to be able to do that process. And people are like that across the board: reading, writing, math, whatever. So we all have different capacities. So in this world, people will also have different capacities. Some people are just like a rocket and they get better. Some people take longer, but the important part for people is to focus on progress. Can I start? Most people are starting from a base of like, I've gotten zero amount better in years. And once we can start seeing progress, that's the win. We just have to keep that going, and you can turn that into great outcomes over time. And that's the important part, is like, can I keep getting provable, measurable victories? And if you can do that and keep that persistent, then the time frame is just however fast we can keep implementing that. So it's a really good question. I'd like to be able to give you an answer like everybody's better in 3 months. It's just, there's just such a large variety that it's hard to say that. And I might say that for you, and it might take 2 weeks, or it might take you 6 months. Either way, that's a better outcome than the trajectory most people are on. So we just try to move forward. Forward is like our main focus. Okay. Cool. Okay. Just reading a couple of these. You guys are being super nice to me. I appreciate that. Mathieson said, thanks for helping. Don't hold back on being ranty. We need it so we can hear the message through our brain fog. Yeah, I try to leave a lot of room open for lots of possibilities for people, not close the door on anything. I don't know everything. I'm just a guy that happens to just like think about this a lot, and I'm just trying to share my thoughts and observations about it in hopes that it just helps more people that way. This is a way that I get to talk to a lot of people, so it makes me feel like I'm being productive. And with that said, there are things I feel very strongly for, but that I don't kind of like over-index toward, because I don't want anybody to hear that and then take the message the wrong way and send it down a path. But there are some things I feel really strongly about, and hopefully as we keep going through these, you can recognize what those are. But mostly I want everybody to be able to have the experience of feeling better. I know what it's like to not feel good. I know what it's like to feel like you don't know when that end point will be, that it doesn't happen. So I'm mostly just trying to get people started on the race of trying to fix it. And the faster you get started on the race of trying to fix it, the faster you can iterate through and get to the end point. So that's what I get excited about. That's why I do these. Hopefully you guys get something from it, some value. And as long as that's true, I'll keep doing it. I really appreciate you guys being here. There's a ton of questions here, a ton of really kind words to each other, kind words to me, really thoughtful questions for yourselves and for others. So I really appreciate that a whole lot. And I'm just really thankful that we can do this, and I will do it again next week. What's the date today? 26th. I don't know what day the 4th of July is. As long as it's not Thursday, I'll do this again. And we'll just keep working forward. So thanks so much for your questions. Help each other out, think about each other, pray for each other, and let's keep moving forward.